Hello, everyone, and thanks for joining today. It's exciting to have a great turnout in person and on Zoom. And so, as Amy mentioned, I'm Kim Stewart, and I'm a Senior Gynecologic Onc Fellow. And today I'm very excited to talk to you about our quality improvement project, Avoiding the Needle. It's a direct-acting oral anticoagulant, Apixaban, for extended venous thromboembolism prophylaxis after major gynecological cancer surgery. And the first thing I want to do is acknowledge the multidisciplinary team that made this project possible. We had a big team, my supervisor, Dr. Justa McGinnis, who is the QI legend, and the rest of our team is listed here. We had a multidisciplinary team of gynae oncologists, hematology, nursing, pharmacy, and health profession students who made this possible. So I want to thank them. So I'm going to start with the problem. I'm going to break down these acronyms that I used in the first line. Venous thromboembolism are clots that are in your legs and lungs, and it is the #1 cause of post-operative mortality after gynae-oncology surgery. And some literature shows almost 10% of patients previously, before the extended prophylaxis, would have developed a post-operative PE. And if you develop a PE after surgery, previous literature shows that up to 1/5 of those people would die. So it's a very serious complication after surgery. Because of this complication and the high rate in our gynae-oncology population, international guidelines for many years have recommended 28 days of extended venous thromboembolism prophylaxis, so a small blood thinner taken for up to 28 days to help reduce the risk of our patients after surgery for blood clots in their legs and lungs. So the worldwide standard has been enoxaparin, which is in the family of low molecular weight heparin. And this is a subcutaneous daily injection patients are taught to take themselves, and they self-inject at home for a total of up to 28 days after an open surgery, or 10 to 14 days after a minimally invasive surgery or a vulvar surgery. And we have been advising patients and prescribing enoxaparin after surgery for over a decade in our population. And in the local context in British Columbia, our patients who undergo gynae-oncology surgery have their surgery here at Vancouver General Hospital or in Victoria General Hospital. And we prescribe this when they go home. And through the BC Fair Pharmacare program, this medication for the indication of post-operative clot prevention is covered by the Special Authority Program for patients who are registered and have met their deductible and are eligible for coverage. So we've been doing this for a long time for our population, and we didn't actually have any idea of how it was going. Were patients taking this medication? Were they not? What was their experience? And so to understand what our patients were going through, we performed a baseline survey, and we called 108 patients who underwent surgery with the gynae-oncology team from August to October of 2021, and we asked them about their experience with the enoxaparin we were prescribing. So through this baseline enoxaparin survey, we started asking patients on a Likert scale of not bothersome at all as 1 to the most bothersome thing ever is 10. We asked them about pain and bruising. And many of our patients, over 70%, reported some issues with pain and bruising, and that makes sense when they're injecting themselves. And over 60% of patients reported some discomfort with the self-injection. And a couple of these quotes we had a lot to choose from are kind of representative of what they shared with us. Participant 43 had issues with petechiae, ended up going to the Merge for this. A pharmacist had to come to their house each day to administer, which was a service they had to fight for. Participant 50 had their family inject the needle, didn't want to do it themselves, and personally would have preferred an oral alternative and doesn't like needles. And many of our stories were like this. And so this was starting to give us an idea that this is a quality of life issue by recommending a self-injection. Fortunately, in our baseline survey, almost 92% of patients told us on the phone after that they were adherent to the medication. You know, there's always some bias when you ask someone, you know, we were asking a couple months after their surgery, did you adhere? Did you miss any? And most of them reported really a high adherence. And so overall, I think this is a really good rate. People understand why we are recommending this medication and understand the importance of it. And although it's challenging for them to take, they were sticking to it. And this is a Pareto chart. It's a type of quality improvement tool to understand the root causes for the problems that we are identifying. And in this particular chart, we took the most common reasons patients were non-adherent to their enoxaparin to try to figure out what was the main cause for patients not sticking to the full course of medication. And you can see on the y-axis there that there is a lot of different reasons that they said, but the most common cause was because of the self-injectable nature of the medication. That was the main reason that they didn't stick to it. And the final thing that we learned from our baseline survey, which was, I think, the most surprising thing, was the financial toxicity our patients were experiencing. As I mentioned before, this medication for this indication had eligibility for coverage through special authority. If you were going to pay for this out of pocket, the enoxaparin for a month, that was about $300. And you can see over 56% of patients paid over $125 out of pocket. And the reason I chose $125 is because that is the oral alternative cost for a month. And we found when we asked, only 19% of patients received coverage through special authority. And during this process, we learned a lot more about coverage. Patients needed to make a relatively low income to be eligible for special authority. And if they made more, if there was a person who was working full-time and they didn't meet it, they would have to pay this out of pocket. And other issues were logistical issues. You know, they have their surgery and then in the hospital, someone needs to fax a form to a government office for approval. So if someone's discharged on a Friday or Saturday, that process might not have gone through for them. And so only 19% of people actually benefited from that program. And I took the average of medications, took the average of people that had it for 28 days. And I averaged the cost in our baseline cohort, and they paid on average of almost $200 for this medication. So that is significant. So our baseline data helped us identify a healthcare quality issue. The main issue is that self-injection is a major issue leading to pain, bleeding, difficulty with administration, and is the reason people don't adhere to the medication. Fortunately, our baseline data shows us that patients seem to understand why we're recommending this, and in their self-report, they adhere to the medication. And the final outcome was that this current prescription pattern creates financial toxicity for our patients. So I'm going to pivot and I'm going to talk about a new alternative for VTE prophylaxis. And I kind of hinted at it earlier. This is an oral option. It's titled Apixaban, and it's prescribed at a 2.5 milligram oral twice daily tablet. It's in the family of the direct oral anticoagulant, and it's a factor 10A inhibitor in its mechanism. So it kind of prevents clots in different ways. And I'm going to walk through a little bit of the literature. Apixaban used to be called a novel oral anticoagulant, but now it's not novel anymore. It's been around for almost 2 decades. So we call it a DOAC now instead of a NOAC. And there's lots of evidence of using the Apixaban in that family for treatment of blood clots, thinning of blood for atrial fibrillation. And in different populations, they have used this for post-operative VT prophylaxis, namely orthopedic populations. But we didn't have that data for our patients in gynecology. And gynecology patients have a high risk of postoperative VTE based on the pelvic surgery that we do, the extensive surgery, the way the lymph nodes are spread can really lead our patients to higher risk of blood clot. And so this initial randomized control trial, which was published in 2020, began to give us evidence, randomized control trial evidence for Apixaban. So in this trial, by Guntapalli and colleagues, published in JAMA Network Open 2020, they wanted to investigate the safety and efficacy of Apixaban for prophylaxis in our gynec patients. And they did a multi-center open-labeled randomized control trial, and they recruited from May 2015 to 2019. The intervention arm was 28 days of Apixaban, and the control was 28 days of enoxaparin. And so these are the results here. They ended up randomizing 400 patients in their trial. And from this table here, you can see that there was no significant difference in bleeding events, clinically relevant non-major bleeding. blood clots, adverse events, medication adherence, or quality of life. They did know that patient satisfaction was significantly greater in the Apixaban group. They said it was much easier to take and there was no pain associated with it. This trial was not powered to be a non-inferiority trial, but it does start to give us really good evidence showing that Apixaban is a safe alternative to the standard enoxaparin. And now Apixaban is starting to take the world by storm. And so this is a paper, this was an abstract actually published by a group in Sunnybrook in Toronto. And they started to introduce Apixaban in November of 2021. And they did a pre and post-intervention cohort analysis looking at their pre-group, which was enoxaparin, and their post-group, which was Apixaban. And their goal was to evaluate the effectiveness and safety in our population. And they used, to look for adverse outcomes, they used the NISQIP database. And in the end, they demonstrated in their two cohorts, the pre and post, that there was no difference in VTE rates or post-operative readmission. So they made the same conclusion as the RCT. This is a paper coming out of McMaster, published earlier, we're not in 2022 anymore, but in April of last year. And they were looking specifically for adherence for Apixaban. And they offered Apixaban for patients after major oncologic abdominal surgery. So they included patients that were after GI surgeries, as well as 27 patients that were gyne-oncology. And they asked these patients pretty strict adherence measures. And it's hard to measure adherence. As I told you before, you know, when you ask someone, did you take your medication? They feel probably the pressure to tell their doctor that they took their medication. And they may, there's also a recall bias as well. And so what they did in this trial is they followed adherence much more strictly. They called the pharmacy patients were getting their medication from. They also called on the day the medication was supposed to end and performed pill counts to find their adherence. And they reported that 94% of patients took at least 80% of the prescribed doses, and they concluded that patients are adherent to Apixaban. And this final paper was published in 2020, and this was an American group. They were looking at the system cost effectiveness of implementing Apixaban versus enoxaparin. And they looked at a hypothetical cohort of 1,000 people, and they calculated the money saved by preventing different complications by Apixaban. And they found in their hypothetical cohort in an American setting that Apixaban was less expensive from a systems point of view. So all of this led to this clinical practice statement published by the Society of Gynecology in 2021, where they add Apixaban as an option for postoperative VT prophylaxis for our patients in addition to enoxaparin. So I hope that I've explained now, you know, Apixaban, it's a twice daily medication that you take orally. It's as effective, patients are happier, they adhere to it, and it's cost effective. So with all of this data, we wanted this for our patients. This sounds fantastic. And so this was the impetus for our quality improvement project. So we wanted to offer Apixaban 2.5 milligrams twice daily as extended VT prophylaxis for postoperative gyne-oncology patients at Vancouver General Hospital. And we took the problems that we identified in the baseline data, that patient experience, and we gave ourselves some goals to improve with our intervention. So the first was to improve their quality of life experience. We wanted to improve those pain, bruising, comfort with administration measures by 50%. The second aim was to improve the self-reported adherence by over 5%. It was really good, but could we get it even better by taking away the injection? And the final was to improve the financial toxicity, to increase the patients paying under $125 by 50%. And if you can recall, the Apixaban, the out-of-pocket threshold was $125. So how did we do it? We took consecutive patients who were eligible for extended VT prophylaxis at VGH from August 1st to October 31st of 2022. And patients that were eligible for this prophylaxis were patients undergoing major surgery with the gyne-oncology team, with a diagnosis of malignancy or other medical comorbidities that would make them at higher risk of postoperative VTE. We excluded patients that were already on therapeutic anticoagulation, such as atrial fibrillation or previous diagnosis of VTE. And there are certain patients that Apixaban interacts with their own medications, for example, some anti-seizure medications, who were also excluded. And what we did is we offered patients a choice between the new option, Apixaban, and the standard option, enoxaparin. And how we offered the patients the choice is we first engaged a multidisciplinary healthcare team to provide counseling. We made a patient education handout, and we created a forced function pre-printed order set, which included this. And I just want to highlight the reason that we kept this as a choice for patients. As I mentioned, enoxaparin is eligible for special authority coverage, and Apixaban is not. And so for some patients, they would be eligible for full coverage with enoxaparin. And so for an equity, for reasons of equity, we wanted to make sure we still offered the option in which some patients may get some financial benefit. And it also actually provided us an opportunity to ask people, like, why did you choose, and understand their kind of values in when choosing this medication. So what we did is, as part of our quality improvement project, we had certain measures to see how we were doing through the project and how our outcomes were. So process measures are looking at, like, how was our education going? How were the pre-printed order sets going? And we surveyed that on a patient phone survey at week 1. And we did that weekly to have these rapid plan, do, study, act cycles to change what we were doing and make sure we were being effective. For our outcome measures, which were the 3 main aims of our study, the quality, adherence, and cost, we performed a patient phone survey at week 4 to 6. And finally, we wanted to make sure that what we were doing wasn't causing harm to our patients. So we looked for balancing measures like rates of clot, bleeding, readmission with a chart audit at 6 weeks. We performed a data analysis using statistical process control charts, P charts, to track and display process and outcome measures, and I'll orient you to those as they come up. And we did some descriptive statistics. And for ethics, for quality improvement work, we reviewed the exemption checklist, and our project was exempt from formal ethical review. So first, I want to talk about the quality improvement processes, so those things that we did to make this project work. So the first part was the multidisciplinary care team education, which started with us identifying who are patient-facing people that would be talking to patients about this option. We identified the surgical team, which includes medical students, residents, fellows, and surgeons, nursing team, both outpatient and inpatient, our pharmacists, and our administrative staff. And we performed education sessions with these teams to orient them to the project and common questions. And these team members provided counseling to patients before their surgery and in hospital. And this is the first P chart. And so a P chart shows the proportion of whatever you're looking at over the longitudinal implementation of the project. So you can see that we have the percent, and then we have the weeks of the intervention on the bottom. And throughout this P chart, and this particular one is looking at the proportion of patients who received their education by a multidisciplinary team. Most patients were spoken to, 60% by the surgical team. But as you can see, there's a trend over the project that over time, more and more patients were receiving their counseling from pharmacists and nursing. And I think that demonstrates how our education sessions were effective. There were a couple drops that we noticed, and through our rapid PDSA cycles, we identified, oh, some of our patients aren't going to the ward we expected, and nurses from different units need education. Sometimes we had new pharmacists that needed education. And so those rapid PDSA cycles allowed us to adapt and do more education sessions to get everyone on board with our project. For patient education, our multidisciplinary QI team created this handout for patients so that they understood the choice offered to them. And we also reviewed it with some patients for readability and understandability as well. And this handout was provided to patients in their preoperative package if it was mailed to them at their consultation and in the hospital. And so here is another P chart looking at the proportion of patients who received the information brochure. And if you look, only 54% in our group actually got the handout. And I'll explain a little bit why. At the beginning, many of our patients had their consultation or their package before our project started as an outpatient. So when they came to hospital, they hadn't received it yet. And then you can see week 6, we're at 0, and that's because I was away on vacation and they ran out of papers at the clinic. And so no one got it that week. And I came back and we did a PDSA cycle and we were like, we need to try to get this into more people's hands. And so you can see week 7, we were on it that week and 89% of patients had it, but that didn't stick. And I think probably it's because the handouts, patients reported getting so many pieces of paper, they may not remember this. And also some patients didn't find it that helpful, but we asked them, people who actually did receive the handout, how helpful was it? And from a scale of 1 to 5, they reported 3.65. So not so bad. But when we asked them, how are you making this decision? How did you decide? They reported that the most influential thing was their one-on-one discussion with their healthcare team members. So really, I think the biggest bang for our buck is engaging the multidisciplinary team. So we all have the same message and information for patients to help them decide. And so in future iterations of this, I don't think we actually need the patient handout, and we weren't very good at giving it out anyways. And the final thing was this pre-printed order set. We worked with our nursing and our pharmacists in the hospital to change this. And this is how we communicate with our nurses on the floor. After the first 3 weeks in which there was a gray period where old order sets were being used, this was used for every single patient. And so we didn't actually track it. And it's also been transitioned to our new electronic medical records, electronic medical system. And so this continues to be a force function for all our patients. So that's how we did it. And now we got to this part of the presentation where I'm going to talk about how we did. These are the outcomes from our quality improvement project. So during our initiative period, which was 12 weeks from August to October, there were 180 patients who underwent surgery with our team. 127 or 71% were eligible for the extended prophylaxis based on the eligibility criteria I shared before. And in the end, 83% of patients chose Apixaban and 16% chose enoxaparin. And we had relatively good participation in our survey. 80% participated in that week 1 survey, and 73% participated in our week 5 phone survey. So this is showing a P-chart of patients who chose Apixaban over time, with the average of 83% I mentioned before. You can see there's some variability week to week. Apixaban was chosen primarily to avoid injection by 90% of patients. And just from my experience, people were like, I would pay whatever I could to avoid injection. And a lot of our patients in hospital, all of them got the injection while they were in hospital before they transitioned. So many of them changed their minds also after getting that injection. And we asked patients who chose enoxaparin, why did you choose that? And the primary reason they said was cost coverage. And a few patients also said they were nurses, and so they were comfortable with administration. But overall, it was because of the eligibility for cost coverage. So our primary aim of the study was to improve our patients' experience with the extended prophylaxis. And so if you remember, over 70% reported issues with pain and bruising, and over 60% reported issues with comfort with administration. And in this bar graph here, the dark green represents the baseline enoxaparin group. The light green were the 16% of patients who chose enoxaparin in our current cohort. And the blue is the patients who chose Apixaban. And you can see, based on these self-report Likert scales, in terms of pain, I mean, it makes sense. They weren't injecting themselves anymore. It dropped from 74% to 1. For bruising, it went from 73 to 20. And for comfort with administration, it went from 64 to 11. And so I think we achieved our primary aim, which was improving the experience for patients. And just from anecdotally talking to patients on the phone, they were so happy. There was a lot of anticipational anxiety with their daily injection they had to give. And taking a simple pill really took a lot of that off, and that's not captured necessarily in this data. So in terms of adherence, just to orient you a little bit to these charts here, there's 4 individual charts, and they represent the baseline cohort, the Apixaban in our intervention arm, and the enoxaparin in our intervention arm, and the final is the chosen therapy. So that's everyone in our intervention arm. And as you remember, there was a pretty high self-reported adherence rate in our baseline, 92%, and we had a lofty goal of increasing it above 95%. And although we didn't achieve that, we had the same adherence rate in our intervention cohort. And I think what we learned here was that Although patients are avoiding injection, there are other reasons people miss their pills. You might forget it at night. One person actually dropped their pill on the ground, so they missed a dose. And so there are different reasons people miss. And so I think that although we didn't increase it by 5%, we still maintained a very high adherence rate in both our baseline and intervention cohorts. And then the final aim that we wanted to improve based on our baseline data was the cost for patients. And so in this graph here, I compare the Apixaban subarm of our intervention with the baseline data. And just to remind you, the typical out-of-pocket cost was $125 for Apixaban and $300 for enoxaparin. And from the baseline data, only 19% of patients received that special authority access and help with their coverage. Patients reported, about half of them had third-party insurance in both our pre and post cohorts. But when we looked at the percentage of patients who paid under $125 in the Apixaban arm, 91% paid less than that, and when only 45% in that baseline cohort paid that. And I took out the patients who got 28 days, and I was curious, how much was their average cost? Because this is a mixture of, some people had 14 and some people had 28. And so I was really wondering, what does this number look like for a patient? An average 28-day prescription for Apixaban was $64, compared to for 28 days, and our baseline cohort was almost $200. And in the enoxaparin arm of our intervention was $230. So it was a big difference. And I think that we reached our aim, which was increasing the amount of patients who pay less. And what's really exciting is that, we finished our project in October, and this has continued on now as a standard for our patients. But as of December, Apixaban became generic, and that made it half the cost. So for a month of Apixaban, instead of it being $125, it's now $60. And then as of January 5th, this magical announcement came out where BC Fair Pharmacare expanded the coverage to cover Apixaban without needing to send a special authority for patients that are eligible for Fair Pharmacare. And so this will make this option even cheaper for patients. And we won't have to be sending faxes, and we won't have that issue with the flow of getting approval as well. And so this is really exciting news in terms of financial toxicity for our patients. The last was the balancing measures. This is the intervention arm, the Apixaban and enoxaparin sub-cohorts. And as you can see here, we had really low bleeding rates. There was no clots in either group. There was a concern, when we were planning this project, that if someone needed to take back surgery, that there would be an issue with the Apixaban, because therapeutic Apixaban you'd like to hold for probably 2 to 3 days before surgery. But, the patients that needed surgery for non-bleeding reasons in this cohort, they weren't affected. There was no delay for their surgery. And the rate of clinically relevant non-major bleeding, which means bleeding that is bothersome, they have to seek care, but did not need transfusion, was very low. So there was no worrisome safety signals, which echoes the data that I spoke about earlier. So in QI fashion, we kind of thought about our project and thought, if we were to do this again, or if another group was supposed to do this, these are our lessons that we hope they would take for a more successful implementation. And the first was cost. We learned in our baseline data, we were shocked, our eyes were opened about the cost experience for our patients. And the nuances to special authority coverage needing to meet your deductible and eligibility. And through this process, we learned a lot more as a healthcare team. And with our information, my counseling changed over that time so that people understood the cost implications of their choices. And I think patients appreciated that because, they might have chosen enoxaparin because the injection's not that bad, but actually the Apixaban would have been cheaper for them. And so we actually engaged people to call their pharmacist in the hospital to see which is cheaper, because we could send them home with whatever prescription they could have a cheaper cost. The second was for patient education. Our handout was not that successful. And so maybe in other places, a handout might be maybe another time during their treatment when it's easier to read, when it's maybe less overwhelming. But really the most effective way of patients understanding these options was the healthcare team recommendations. And so I would recommend that education piece and engaging a multidisciplinary team is the best way to make this successful. And the last is I want to acknowledge that there's a limitation with self-reported adherence. We talked about that a little bit. I think that we had really good adherence in our pre and post, but it's obviously influenced by some bias. And there are other ways to study adherence, but it is really hard. But I think overall our patients understand the importance of this medication and why they should take it. So we got to the end. Our conclusions, the first is that patients prefer oral medications. It minimizes their pain and bruising. They adhere to it, so the pill is a winner. The second is Apixaban's cheaper, and after January 5th, it's going to be even more affordable for our patients. The third was implementing a forced function PPO, the pre-printed order, and a multidisciplinary team. That's an effective way to implement this, and this is now an integrated standard process for all of our patients at VGH. And finally, we contributed to the growing literature on safety of Apixaban in this setting. And thank you again to our big team that helped make this possible for our patients.